Code word. Go ahead, Simon.
Okay, welcome to day 2 of our NSF Prepare Vaccine-preventable disease workshop. I'm Simon Levin from Princeton University. I'm one of the co-PIs for Prepare. And for those of you who weren't able to join us yesterday, I'd like to take just a few minutes to tell you about Prepare. Prepare is an NSF-sponsored virtual organization of multidisciplinary researchers who are interested in developing the scientific foundations and the engineering principles for planning and responding to the ongoing and to future pandemics. So we invite you to join us as we build a community of pandemic science, researchers who can collaborate on cutting-edge science, encourage resilience, and attack the next pandemic head-on. And here, thank you to our fantastic program committee for bringing together this superb group of experts. And also, I want to thank the entire Prepare team for their dedication in supporting this workshop. Please visit our website if you want to learn more about our goals and the progress we've made toward building this virtual community. So we're excited to have you with us. I'm really looking forward to these speakers and the discussions. And now I'll hand things over to Yang Liu and to Anil Vullikanti, who are going to be the session chairs for our first panel today.
Thank you, Simon, and welcome everyone. My name is Yang Liu. I'm an assistant professor at the London School of Hygiene and Tropical Medicine. I'm also an infectious disease modeler, and our first session today is on epidemiological and immunological factors in VPDs. Our first panelist today is Professor Jessica Metcalf from Princeton, where she's an associate professor of ecology, evolutionary biology, and public affairs. Jessica is a demographer with broad interests in evolutionary ecology, infectious disease dynamics, and public policy. She completed her PhD at Imperial College on the evolutionary demography of monocarpic perennials. Her postdoctoral research was conducted in various institutions. She studied the evolution of senescence at the Max Planck Institute of Demographic Research, the inference of tree demographic parameters at Duke University, and infectious disease dynamics at Pennsylvania State University and Princeton University. Jessica's teaching focuses on a course titled Epidemiology and Ecological and Evolutionary Perspective. Her course aims to communicate both an understanding of the core principles of epidemiology, ranging from classical study design to core analytical techniques, and a broader perspective into the fundamental drivers of health outcomes, ranging from ecological drivers of the spread of infectious disease to the evolutionary determinants of profiles of late-age mortality. If you have questions for Jessica or any of the panelists today, just add them to the chat and we will address them together at the end. Take it away, Jessica.
Thanks so much, Yang. It's been a wonderful session so far, and thanks so much for inviting me. Can you, oh, sorry, wrong screen. So, let me try this again. Sorry, I don't know how I managed to do that. Can you tell me which screen you can see?
Right now it's just your desktop, and now it's revealing risks, anticipating feedbacks.
And can you see my notes?
No.
Brilliant. Okay, thank you.
Looks perfect.
Confusion. All right. Well, I think it's clear, I think, to everyone here that vaccines are really an important public health tool. It's actually both quite difficult and quite easy to figure out precisely how beneficial they are. It's easy because since we know a lot about the mechanisms of transmission of infectious diseases, we can lay down expectations for what the counterfactual would be if we had not vaccinated at all. But the difficulty lies in the fact that, of course, the devil is always in the details, and so there can be a lot of nuance around precisely how much mortality was averted, for example. And the Vaccine Impact Modeling Consortium put together a team to look at sort of build a consortia of models where you could synthesize the different decisions that different modeling teams could make. And for example, put together figures like this one, where you can see that the deaths averted by measles vaccination are probably in excess of 1.5 million or more. So clearly, vaccination is a key public health tool. And this, and for this line of evidence, many other lines of evidence have prompted individuals many people at the start of the pandemic to make the case that vaccination should, of course, immunization should be kept really front and center going forwards. Again, it's hard to do this with precision. It's hard to decide precisely what the costs and benefits are, what the advantages of maintaining vaccination programs are, given the challenges. But a similar leveraging of what we know about the mechanism was employed in this space. But sadly, of course, as Carolina De Navarro introduced much more completely and thoroughly yesterday, vaccination programs were inevitably disrupted by the SARS-CoV-2 pandemic. And this shows disruptions to routine measles vaccination over the course of 2020, both globally and in the different WHO regions. With particularly AMRO, you can see the American region, you can see a deep drop in the start of 2020, but also visible in many other settings. This is routine programs. We can also see disruption to campaigns. And again, this is something that Caroline De Navarro touched on yesterday with great thoroughness and detail. A number of vaccination campaigns were postponed. Many have been reinstated, but of course, with the loss of time concomitant upon them. The unprecedented efforts that came in the wake of this disruption did provide some opportunities in terms of thinking about how campaigns are tracked and how campaigns might be coordinated. So there's no silver lining, but it's still, of course, clearly has been a very difficult situation. And something that other speakers yesterday also touched on was the fact that even accounting for beyond the disruptions driven by the COVID pandemic itself, COVID vaccinators are also both an important public health contribution, but likely to deviate resources from other settings. And this is just some work by Fidisu Razambainari from Madagascar, looking at the number of healthcare workers against population size in different regions of Madagascar. And here the question was to look at how SARS-CoV-2 vaccination efforts might be deployed against Madagascar. But I think the scale, the fact that the number of healthcare workers per 1,000 individuals is often much less than one in many regions in Madagascar highlights just how hard it will be to maintain both SARS-CoV-2, to both existing programs and deviate attention towards SARS-CoV-2 vaccination. And this is again something that has come up repeatedly in many of the talks yesterday. So many sources of disruption to vaccination programs and the start of evidence that cases are beginning to surge in different places. A few papers have been published. There's been some work on Burundi, some work in Pakistan, which is sort of rather what we'd expect, a growth in cases in the wake of disruption of immunization. There's another way which Kerrigan McCarthy hinted at in her presentation yesterday, where we might expect intriguing disruptions of the epidemiological dynamics of measles. And that is the fact that alongside the vast disruptions of measles immunization programs, there were also vast disruptions to human behavior in ways that, naturally enough, were likely to disrupt transmission of immunizing infections, vaccine-preventable infections alongside SARS-CoV-2. So all what does NPI stand for? Non-pharmaceutical interventions, got it. So all the non-pharmaceutical interventions thank you, Ray, that were driving down SARS-CoV-2 transmission are also expected to have an impact on other directly transmitted infections. And Ben Rice and colleagues looked at this in an evaluation that attempted to anticipate what the trajectory of the pandemic might be in sub-Saharan Africa. And here he's plotted the stringency index, which integrates many of these non-pharmaceutical interventions provided by the Blavatnik School of Government in 4 just exemplar countries over the course of 2020. And you can compare this to data from the World Health Organization on monthly measles cases. So the gray lines on these plots show monthly measles cases across the years from 2011 to 2020, with 2020 shown in red. And the message here is very mixed. So Madagascar had a very large measles outbreak in 2018, 2019. So you'd expect a large amount of susceptible depletion and not much of an excess in 2020. And this is indeed what we see. In Kenya, cases are pretty much look very much like other years. But if you look towards Ethiopia and Germany, as the stringency index goes up, you can see that at least there's a suggestion that cases of measles are falling below what they do in other years. So it's possible that transmission is being disrupted by drivers that are disrupting the transmission of SARS-CoV-2, efforts to disrupt the transmission of SARS-CoV-2. Again, of course, it's very hard to interpret this entirely because, as Kerrigan McCarthy noted, all of surveillance was also being affected. So fever rash samples, which are the basis of this data, were going to fall. But at the same time, she also noted that it looked like rubella transmission had been driven really to low levels in South Africa, possibly even been eliminated, she suggested. And you saw the same thing for Hep A. So it's undeniable that these sorts of processes are also likely to come into play and should be considered in thinking about what the trajectory is for vaccine-preventable diseases in the coming months and years. And the issue is, of course, both disruption of vaccination programs and the buildup of susceptibles due to reduced transmission is going to shape the pool of susceptible individuals. And this was addressed in detail by Rachel Baker, looking at a different set of infections. So in this particular case, we're looking at numbers of influenza cases. And in fact, the change in positivity associated with influenza, again, over the course of 2019 through to 2020, in different states in the United States. And you can see that it's sort of at the start of non-pharmaceutical interventions, which is shown by the dashed line falling vertically across this plot, cases just kind of fall off the map. You get very few cases because people are not in contact anymore, so transmission can't occur. The reason we care about this particularly in thinking about management of vaccine-preventable diseases, but also the dynamics of other infections, is that if you consider what this will do to the dynamics, in the absence of such disruptions, the lower lines on both these panels, which are exemplars for different states, show numbers of cases through time. So you usually get an outbreak every year, as shown by the red line. But with the disruptions in 2020, shown by the gray bar, no transmission occurred or very little transmission occurred. And as a result, the dashed blue line at the top shows buildup of susceptible individuals. Nobody's getting immunized. There's more and more susceptible individuals over time. And what that means is that if you have more susceptible individuals, you have a risk of a very large outbreak after once the non-pharmaceutical interventions have been released. And this is something that Anton Camacho mentioned as well. One of the challenges facing many public health institutions at the moment is not just how to manage vaccine-preventable disease susceptibility, but the fact that for many infections, and some for which we don't have vaccinations, we're getting out-of-season outbreaks and large out-of-season outbreaks, presumably as a result of this buildup of susceptible individuals. So susceptible in buildup of in vaccine-preventable diseases, so buildup of individuals who are susceptible to being infected with vaccine-preventable diseases, is the world we're in at the moment. And this is occurring both because of disruption of routine vaccination and campaigns, and is possibly also a contribution from reduced transmission driven by non-pharmaceutical interventions. And the risk associated with this is that of unusually large outbreaks. So the question, of course, the question that has been discussed with much nuance and detail over the last day is how can we meet this challenge? What are the things we can do and what are the things we can think about? So in putting this talk together, I turned back to some of the work we'd done in the wake of the Ebola outbreak. And in there, we were specifically thinking about, what should the focus be in the context of this large outbreak. And we were particularly concerned because the measles risk prior to Ebola had been pretty substantial in many of the affected countries. But if you imagined that routine vaccination programs would be disrupted, you could end up with a very large measles risk after 18 months. And in fact, the number of deaths could have really dwarfed the number of individuals who had died from Ebola. It is easy to sort of take your eyes off the routine sort of burden of mortality associated with these infections. And this is something that Bhargavi Rao also mentioned, that the ways in which the interactions between these different programs, the way that which attention is sort of pulled around by the more dramatic events and thus reduce concentration on these routine programs, which can be so life-saving. Another thing that came out of this work that I think it's important to consider is that when we looked at where the susceptible patterns were falling out, what we saw was that the pattern of susceptible individuals associated with Ebola, and this is work led by Saki Takahashi, was extremely heterogeneous through space. So you can combine what we know about vaccination coverage through space with what we know about the pattern of where the density of susceptible children are, and you can see the growth over the course of months of disruption is extremely distributed across here. Sierra Leone, Liberia, and Guinea is distributed extraordinarily heterogeneously. And in fact, there's a big concentration of susceptible children and right around the sort of transnationally crossing those borders. And the happy outcome of this in this setting was that there was actually large national measles vaccination campaigns that were carried out and that reduced those pools of susceptibles, and it seems like that averted the worst of a potential measles outbreak. The important point being that this was a transnational problem, and the coordination of campaigns was a powerful part of the response. And I think it's always worth keeping in mind this subnational heterogeneity in vaccination coverage, in demography, is really ubiquitous. And the ways in which we plan to try and meet these challenges, this is just from another piece of work that Saki put together, is going to require encompassing this heterogeneity in risk. So everything suggests that there is susceptible buildup of vaccine-preventable diseases, particularly the presentations from yesterday. And all of this work, I think, points to a need for vaccination campaigns, for vaccination catch-up efforts. But we also know that this is happening in a context of very seriously stretched health systems for vaccination, vaccinator fatigue, as mentioned by Carolina De Navarro, and a very heterogeneous landscape of risk. So there is a question of how we manage and the ways in which we can leverage the information we have to better and strengthen targeting in this setting. And this is often a challenging problem for vaccine-preventable diseases because we often don't know exactly where we are in some sense. So this is some work put together by Amy Winter, thinking about specifically measles and rubella in the context of elimination. But she makes the point that if you think about cases shown here as the red bars on the top versus susceptible individuals shown as the sort of lighter colored bars on the bottom, what we'd like to be is in a situation where the red bars have gone to zero, so local elimination has occurred, but we're maintaining the susceptibles also at very low levels by our efficient vaccination campaign. So that when measles is reintroduced, if someone turns up with measles, there can't be an outbreak because there's no susceptible individuals to infect. Of course, the concern is that you might actually be in a situation where the vaccination program has not been doing as well as you hoped. And so that when the reintroduction happens, there's a large outbreak. And this could happen again, you might drive it extinct again, but there could still be this buildup of susceptibles that could then lead to another big outbreak, a large number of cases of your vaccine-preventable infection. And one of the things we thought about a lot in this context is the degree to which, the problem here is if you're just looking at cases, you can't see what's going on. You're in that honeymoon period. There's no information about what the risks are of the outbreak. And clearly, one of the ways in which you can tackle this is by focusing on, by turning around and working to measure the proportion of the population that is susceptible, to get a sense of where the population at risk actually is. And this is something that we've spoken about a lot over the course of the pandemic and also before, is the ways in which we might be able to leverage immunological information, which presents, a useful measure of the state of the landscape of immunity in order to better targeting across different vaccine-preventable infections, but that might also bootstrap efforts towards strengthening our understanding of immunity through to different chronic infections. And this, I think, goes in hand with even before the SARS-CoV-2 pandemic, people were beginning to think about ways in which we could shift from a campaign-focused approach to measles vaccination in many of these resource-poor settings to a much more targeted approach to vaccination campaigns. And this is sort of necessary both in thinking about harboring resources and thinking also about fatigue in populations that are being vaccinated often. And of course, the flip side of this is that one should not neglect an opportunity to vaccinate if it's there, and this should certainly be a very conservative approach to the way targeting should happen. Madagascar had a very large measles outbreak in 2018-2019, following years of rather good vaccination and very low numbers of cases. So vaccination coverage is shown on the top of the plot to the left, and the number of cases is shown on the bottom plot. And after nearly a decade of really very low cases, this large surge in cases happened. So it's precisely that honeymoon situation described. And it was fairly heterogeneous across the country in how it played out. There had been some anticipation that this might be an issue using various WHO tools, but action could not be taken given issues in financing ahead of this outbreak. There were many challenges. In the wake of this outbreak, Ansur Haririndrasana put together a team to think about what one could learn from this measles measles outbreak in order to think about how targeting might be improved and one might be able to get ahead of such processes. And she mentioned in this paper the importance of serology, but she also pulled in various different threads of information, sort of generally trying to leverage all the information that is available in order to identify where the most important susceptible populations are and how vaccination targeting could most efficiently occur. And this was in collaboration with, so she was sitting in the Ministry of Health, and it was in collaboration with the World Health Organization and other partners. So I certainly, I mean, it's not rocket science to say we should be leveraging all the information that we can, but I think there's also some really interesting ideas floating around now about how we can really get the most out of the data that we have, for example, on serology. And this is some very interesting work led by Arthur and Soloheri, who sits at, so Arthur is a PhD student at Princeton, and Soloheri sits in the Institut Pasteur of Madagascar. And they were working with some cohort data that had measurements of serology associated with both diphtheria and pertussis. And Arthur had the great insight, because this is a multi-antigen vaccine, so the DPT vaccine is delivered to children throughout Madagascar, you actually can use the fact that you have both antigens together to get a sense of what that vaccination coverage is, based on the very simple insight that, you know, there's going to be children who are negative for both, children who are negative for one and positive for the other, and children who are positive for both. And amongst the children who are negative for one and positive for the other, there's a clue there in terms of what they're likely to have been infected rather than vaccinated. And this likelihood is absolutely rooted in what we know about, you know, the false positive, false negative rate associated with the different serological tests, but gives you a way to sort of pin down what that proportion is that might be unvaccinated, which is this really important concept in getting to grips with this. So by having these two different antigens associated with the one vaccine, you can begin to get a much more refined image of what that landscape of immunity is and where vaccination targeting might happen. I think this is the start of a really interesting set of work, all of which is connected around integrating different data streams, integrating different sources of information to get a sense of what this landscape of immunity looks like. I think, and this is something that Carolina and many others also suggested in their talks yesterday, clearly targeting is going to be important in the months that come, but ultimately what we'd like to do is have strong, stable, resilient health systems that can meet these challenges and not suffer complete disruption. So this is some work by Farah in Madagascar, again, looking at the impact of strengthening of health systems. So not looking at targeted vaccination per se, but just looking at what happens if you strengthen the health system in general to vaccination coverage for different antigens. And they compared inside and outside a catchment and showed that within a catchment, this is comparing different years and different antigens, there's been a considerable improvement since 2014 in many different, for most of these different vaccines, but the improvement inside a catchment area where you'd attempted to strengthen the health system in general was much higher than the levels outside the catchment. So I think where we are, VPDs in the post-COVID world, in the short term, we need to think about targeted catch-up efforts to build in immunization in this context of this challenged health system. But we can also leverage some of the things we've learned in the wake of COVID, so to build better situational awareness. There was many really interesting innovations, such as using blood banks to get a sense of what the proportion immune to SARS-CoV-2 was in the population, but obviously you could turn that to thinking about many other pathogens, many other antigens, many other vaccine-preventable diseases. And of course, I think in the long term, where we want to be walking towards is not these targeted responses, but more strong health systems. And I think, again, many of the talks yesterday spoke to the enormous challenges around hesitancy in the context of vaccination, as well as, healthcare worker fatigue. So it's certainly not an easy ask, but I think it's clearly the desirable future to aim for. So there is one question, and Prepare is very much about thinking about innovation in this space. So whether there is anything we could do to speed up in the medium term, to make things happen faster in the immediate term, to move us towards a situation where we have a degree of control over these vaccine-preventable diseases so that their burden is minimally disruptive in this context. Turning again to work by Amy Winter and Matt Graham, they looked at, took a sort of 1,000-mile view of what the dynamics of measles looked like across the world, in fact, and plotted a mean incidence per 100,000 on the y-axis here against the coefficient of variation. So that's how variable the numbers of cases are over time. And naturally enough, as time goes forwards and vaccination coverage goes up, what you see is that you move down this arrow. So the mean numbers of cases is just going to go down. That makes sense. But you also see that the variance in the number of cases goes up quite starkly for a while. And this is presumably because what you're seeing is these phases of buildup of susceptible individuals, and then these big outbreaks following reintroductions. So very explosive dynamics. And then eventually, as you move further towards elimination, that coefficient of variance starts coming down as well. And you've got a mean of 0, coefficient of variance of 0. That's where you want to be. And this seems to be this, we call this paper the canonical path to elimination. It seems a very consistent trajectory. And the question is, can we shortcut through it in a way? And clues potentially emerge around the ideas of this prospect of a honeymoon. So if there's a honeymoon where there's very low cases in any setting in the world, one thing that has been extremely apparent over the SARS-CoV-2 pandemic is that infection anywhere puts other places at risk. So the more places you could put into this honeymoon period, into this instance of low numbers of cases at the same time, the better placed you might be to move towards elimination, to really keep every place in a good situation at the same time. And so Amy Winter put together a vast simulation looking at all the different countries, everything we know about these different countries, and looked at what would happen if you could coordinate this honeymoon periods, if you could line up your campaigns in such a way as many, many places in the world at the same time had low numbers of cases, which means they were not putting each other at risk. And what would it take to create a window of opportunity where you might be able to drive measles or other infections down to sufficiently low levels that perhaps you could even eliminate or create global eradication? Because critically, elimination anywhere means less introductions anywhere else. And the issue of coordination is going to be paramount, therefore, in building the sustainable maintenance of elimination. So just to sort of conclude, and I think many of the messages of this work are pretty straightforward and have been said with much more completeness by many of the speakers yesterday, but susceptible buildup has clearly happened, both for vaccine-preventable diseases and other infections, indicating a risk of large outbreaks in many settings. We probably need vaccination campaigns or targeted increases in coverage to mitigate this risk. And we can potentially leverage many innovations developed during the pandemic, from use of blood banks to measure the immunological landscape, from integration of different programs, there's much more coordination across programs seems to be happening, to leveraging different data sources, but also new approaches, new ways of looking at the serological data, such as that developed by Arthur and Soloheri, to start thinking about how this might happen. Carolina has also referred to, we are in a place where, despite all the challenges, despite the hesitancy, etc., it certainly makes sense to think about strengthening health systems and working to build back better. It is an opportunity, a kind of one with many, many challenges, but one could see it that way. And coordinated efforts because of the externalities, because of the way spillovers work, these are always going to be a stronger approach to thinking about vaccine-preventable diseases. And so this work was very much driven, the first authors of all these various pieces are shown at the top there. So Ben, Rachel, Arthur, Soloheri, Ansu, Fidi, Saki, Amy, and Farah. And some of the papers that I mentioned are listed here, as well as funding from the Wellcome Trust, Bill and Melinda Gates Foundation, and Princeton High Meadows Environmental Institute and the Center for Health and Wellbeing. Also worked very closely with Matt Farry, Brian Grenfell, Justin Lester, and Amy Wazalowski. And thank you.
Thank you, Jessica. Really, really great presentation and very thought-provoking as well. Remember, if you have any questions for Jessica or any of other panelists, please leave them in the chat box. Our next panelist is Professor Deirdre Hollingsworth. Deirdre is an infectious disease epidemiologist who uses mathematical models and statistical analysis to study the evolution and transmission dynamics of infectious disease with an aim of informing the design of more effective control interventions. She's particularly interested in neglected tropical diseases, a group of diseases which cause suffering amongst the poorest populations of the world. She leads the NTD Modeling Consortium, an international network of neglected tropical disease modelers. Her research foci are lymphatic filariasis, visceral leishmaniasis, and a group of intestinal worms, including soil-transmitted helminth, which affect a large number of children and adults in low-income countries, in low-income settings. She has ongoing interest in the transmission and evolution of HIV in both Africa and European/North American settings, as well as malaria and influenza. Whenever you're ready, Deirdre.
Thank you very much. Can you hear me okay and see my slides?
Yes.
Great, thank you very much. Thank you very much for the invitation, and thank you for that introduction. So I'm going to talk a little bit about neglected tropical diseases. I'm very grateful to the organisers for this invitation, and thank you to all the speakers. I'm also going to repeat some points that have been made over the last 2 days, but that's why I think it's really interesting that you've brought different areas together for this discussion. So thank you very much for that. As you were just saying, neglected tropical diseases are a group of diseases which have been brought together really for advocacy reasons. They predominantly affect the poorest populations of the world. They're fungal, they're viral, they're bacterial, they're helminths. They're also non-transmissible. So snake bite is now a neglected tropical disease. I'm only going to focus on a small group of them, which I'll talk through. But they are often described as affecting the bottom billion, and they perpetuate the cycle of poverty. Although they have a number of them are associated with mortality, there's also this big chronic burden of morbidity associated with these diseases, which may be stigmatizing or may lead to people not being able to have an income. And so you see this perpetuation of the cycle of poverty. And they're included in Sustainable Development Goal 3. And there is some language in there which suggests that it is a marker for universal healthcare, because in some ways, these people are at that final mile. And so if you can provide these people with treatment or prevention for these diseases, then you're probably reaching people who are at the furthest end of your health system, which may not be remote. It may be within a city, but it's often those lower strata of socioeconomic groups. So just giving some examples here. River blindness, for those of you who've been to WHO Geneva, outside the building, there's a statue representing this situation. In some villages, the prevalence of river blindness is so high that you were likely to go blind by adulthood, and so children had to lead the adults who are then possibly leading grandparents. Leprosy, which many of you will have heard of, and sleeping sickness. So they're just to give you some examples to orient yourself which diseases we're talking about. So for neglected tropical diseases, I may use NTDs. I'll try and keep saying neglected tropical diseases. So what happened in response to the COVID-19 pandemic? Well, the WHO issued interim guidance in April 2020, suggesting that most of the activities would be suspended and postponed, but of course suggested that treatment and diagnosis of acute cases should be continued, but we know that there were challenges in maintaining those. And then in July 2020, they issued revised guidance, which said basically you needed to do risk-benefit analysis, but if you could do that and you were able to get your program out, you should. So a surprising number of programs did quickly adapt, and they did even start treatment in September 2020, but we know that gaps continue to today. Now, I'm sure a number of you will be aware of this WHO Pulse survey, which covered a number of diseases, but NTDs, as always, came out at the bottom. So the proportion of countries reporting severe disruptions to NTD activities was the highest of all health services. And amongst those, mass drug administration, which I'm going to talk about in a minute, was reported to be the most frequently and most severely affected of all the neglected tropical disease services. And as has been discussed in various presentations, we know that that's partly driven by diversion of existing resources, including human resources, and changes in human behaviour, but also because the rates of spread of neglected tropical diseases are generally quite slow, and as we say, it's not high rates of mortality, and so it's likely to get deprioritised in this situation, as they often are for many reasons. And then on top of that, in the UK government, also one of the major donors for neglected tropical disease control, withdrew their funding quite abruptly. And so while there has been a short-term response to fill that gap, an amazing response, we're still unsure about the long-term impact of that cut. So this is kind of in the modelling sessions. There was a lot of modelling work requested by funders to look at the potential impact of interruptions to NTD programmes on due to COVID on NTDs. So I work with the Bill and Melinda Gates funded Neglected Tropical Disease Modelling Consortium. We focus on a subset of the neglected tropical diseases, which were a subset of those which were highlighted in the London Declaration in 2012. So most of our work is focused on diseases which are controlled by mass drug administration, but we also work on a few other diseases. So we had a sort of a stream of related publications from a first report, a viewpoint. We worked with the African regional office for WHO, have an expanded special program for the elimination of NTDs. And we published a number of papers, and we also worked with the World Health Organization to write a report on the potential impact of COVID-19. And I'm going to summarize some of those results here. So again, to orient you around neglected tropical diseases, there are many different ways in which the prevention and control is in place, but the two ones I'm going to talk about today are mass drug administration. So that's where you go to a community and you give a large proportion of the population a treatment. For some, it's school-based deworming, for example. For other things, it's community delivered house-to-house drug delivery. It's often delivered by community drug distributors. And the sorts of questions we get asked are who should be treated with which drugs for how long. And one of the challenges is what is the role of systematic non-access, which I'll talk about again in a minute. And then we have the other group of diseases, which are, we would say, intensified disease management or case finding. So you try and control the disease by trying to find all the cases. The problem with NTDs is there's very poor diagnostics generally, and in particular for these diseases, for example, with leprosy, we only see the tip of the iceberg. We see the people who get sick after many years. Same with visceral leishmaniasis. We know we don't see the whole pool of infected individuals, and we have very uncertain natural history. So that's a very quick summary of those. So when we were asked to model the impact of COVID, we did it within sort of a general framework for the mass drug administration diseases. So we assumed that they're often yearly, these mass drug administrations. So we assumed for some example scenarios that in 2019 that we had the drug delivery, March 2020 it wasn't delivered, March 2021 it wasn't delivered, it was delivered. So that often was what happened. So that's my thought model. And if we think about mass drug administration, if we start with some level of infection in the community, we do a mass drug administration, the level of infection in the community drops, and then it slowly climbs because these are quite slow epidemic growth rates for these diseases. This is an example of schistosomiasis, which is a blood fluke, which is transmitted through basically excreted in urine or feces and then contaminates water. If we had come back in 2020 with our next MDA, we would have seen a corresponding drop and a drop and a drop of infection. But instead, we're on the black line and we've had missed around, but we start our program as regular here. And you can see that the delays to mass drug administrations will lead to a greater number of infections in the community. That's both prevalent infections that are untreated and some new cases. So we'll see an additional burden of infection illustrated here in the yellow. And we'll also see a delay to elimination as a public health problem, which is the target of many of the NTD programs. So we'll see this extra burden of infection and this additional time to reach the goals. At the same time as we were being asked to estimate the impact of these interruptions, we were also being asked, well, what could we do to mitigate it? And so we were asked to, for example, for schistosomiasis model here on this red line, if you could get higher coverage when you came back, or you could perhaps treat adults as well as children in this example, you could perhaps come back faster and maybe not have such a long delay to reach the goal and not have as big an impact on additional morbidity. So in general, the longer the delay to the MDA and in higher transmission settings, you're going to see a bigger impact of the COVID-19 interruptions, which is not a surprise. And remedial strategies could catch you up. But the thing is that these are quite speculative, these additional strategies. So for example, for some national programs, additionally treating adults for schistosomiasis is an aspiration, but actually getting high coverage in adults is a real challenge. So as one example of something that had been considered already for trachoma, which is a bacterial infection, which can lead to blindness, we found that because the bounce back rate between rounds of MDA is so slow in many settings, in most places, missing one round of MDA will not significantly delay the control efforts. And then in the middling settings, maybe not so bad. But it was only really in the high transmission settings that we thought that a delay to a missed mass drug administration would really have a big impact. So here we have someone which has a very high prevalence of the disease associated, the early stage disease associated with trachoma infection. And we see round after round, our mass drug administration is not really having a big impact. It's really kind of stabilizing. And this is believed to be the situation in some areas in Ethiopia, for example. It's not really fully understood why that happens. Then you miss a mass drug administration and then you just come back to sitting on this kind of stable situation because you're not treating frequently enough to really drive the infection down. And as a consequence of trying to mitigate the impact of a missed mass drug administration in these areas, enhanced mass drug administrations are now being considered and trialled in the field on large scale in a way that they were not before. So multiple rounds of treatments, 2, 3, or 4 rounds of treatments, and then you start to shift these programs into areas that they can really maybe achieve control. But we still don't fully understand, in these models, we can come up with a number of different mechanisms by which we get these stable equilibria under treatment, and we don't really fully understand which of those is true, but hopefully these enhanced programs, which have been innovative as a consequence of COVID, may actually transform the long-term prospects for these areas. As in all health interventions, we have some language around systematic non-compliance or non-adherence or non-access. So we have groups of individuals who we know are not able to access or do not want to access neglected tropical disease programs. There's diverse drivers of different populations. It's often systematic. It's often repeated lack of access. And so for the diseases that we work on, it's lack of access to the mass drug administration. It's lack of access to the vector control. It may or may not be associated with a higher risk of infection and transmission. And also they may not be included in our surveillance. So we know that there are biases in our surveillance, and these people may also be excluded from that. And we know that all of these will have an effect on both the efficacy of the interventions and on the equity impact of these interventions. And we know that the whole advocacy around NTDs is about equity, and yet we really don't fully understand how these interventions affect are dealing with that equity on the ground. We have some data to inform modelling. So this is a study, a very large study on soil transmitted helminths treatment in Kenya. And this is looking at who was getting multiple rounds of treatment. So here we have individuals with the light blue. This is the number of individuals who got all 4 rounds, through to, on the right-hand side, individuals who didn't receive any rounds. And they found that non-treatment was associated with specific socio-demographic groups and did not occur at random. But those demographic groups may be different in different settings. And then the onchocerciasis control programs for years have had treatment registers, which actually show even in a program which has a treatment register, so they really know everybody in the village and who they expect to treat, that there are some individuals who do not receive any treatment even after 3, 4, 5 rounds of treatment. And so in our models, we try and represent this in different ways. And I'm not going to go through this in too much detail, but you can imagine we have random treatment through to a group who always on the right-hand side, a group who get treated every time and a group who don't. And we would like to be able to include more detail from more detailed studies. And my colleague Juliette has done a network analysis of community drug distributors for schistosomiasis and showed basically that friendship networks, etc., affected who got treated in a mass drug administration. So, to stay with that point, I think we know that this is a huge uncertainty in any projections that we give, particularly because we know also our surveillance is probably biased. So it's a challenge for us, and we don't know how COVID has changed that. As a slight aside, we have been working with the WHO regional office in Afro, the expanded special project for the elimination of neglected tropical diseases, to try and provide our results rather than the general scenario that I just presented at the start, but to provide them really at a subnational level so that programs can look at, well, we missed this round in 2018, but then we did high coverage in 2019. So now what's going to happen in our district? And Chris Whitty, who's of course now very famous in the UK as the chief medical officer during the COVID pandemic, wrote what I think is a really interesting question, really interesting paper about providing science for policy back in 2015. And in terms of modelling, he says in that paper, it's best to provide an interactive interface where the policymaker can change assumptions. So we're working on that, and it's a number of technical challenges, but always interested if you want to have a look and see what you think of what we're trying to do. So I then want to talk about the other type of intervention for neglected tropical diseases, which is that this case finding, so that you manage your level of infection in the community by finding cases and trying to drive transmission down. So this again is another schematic on the right. So if we think about a disease where we have some endemic level of infection in the population, and by chance on top of this are, so the solid line is true incidence of visceral leishmaniasis, and then the dashed line is observed incidence, because we don't diagnose all our cases, and then dotted line is deaths due to untreated visceral leishmaniasis, so that's people who are not found. So let's consider a situation where we suddenly increase our case finding. So the consequence of increasing case finding is that you find more cases, and sometimes for policy that can be quite a challenge, that you suddenly have a surge in the number of cases. So I think there has to be quite careful communication around that being a good thing, that they're now finding more cases. And eventually, as you start to find more cases, the underlying burden of undiagnosed cases starts to fall. And then you run into a situation where you are slowly driving down the level of infection in the population, and your observed and your true incidence start to align. There's still an underlying challenge, even in this good situation, is that our surveillance and our intervention are the same thing. So when you have case finding, the cases that you find are your only source of information. For most of these diseases, we don't have an indirect measure of transmission. So then if we consider the COVID-19 pandemic happening, what happens is your case finding drops off a cliff really for a lot of these diseases. And so your observed numbers of infections dropped, but in the background, your true number of infections and the underlying deaths associated, for example, for visceral leishmaniasis with those infections starts to climb. And we're really flying blind. We really don't know what's going on because our surveillance and our intervention are the same thing. So when the intervention breaks, the surveillance breaks. And the challenge with most of the neglected tropical diseases in this group is we have huge uncertainty about the underlying epidemiology. And so we can't really estimate, even from good, if we have good information in this period here, we really can't estimate what's going on in the background under COVID conditions where cases are not being found. And that's a really big challenge for neglected tropical diseases. And this has been recently really clearly highlighted. So Brazil is one of the countries that has a very relatively high rate of leprosy incidence. And you can see the leprosy incidence has just dropped off a cliff. And with a disease which has a very long incubation period, we know that changes in policy take a long time to have an effect. So we know that that's failures in diagnosis. And then we see this increase in people who are diagnosed in the later stage of infection. So we're seeing a higher burden of disease. So neglected tropical diseases do not have high epidemic growth rates, but there still is this slow creep of a burden of infection that we think is building over these years. And if these programs are not brought back stronger even than they were before, this backlog is going to take a long time to clear. So delays or interruptions due to COVID-19 will lead to increases in infection and morbidity due to these diseases, and increased time and resources to reach the 2030 roadmap targets. But it's really dependent on the disease. So for lots of neglected tropical diseases, there will be almost no impact at the population level, but there will be new infections that could have been prevented. But amongst the diseases we work on, in high transmission areas for schistosomiasis, trachoma, and visceral leishmaniasis were the areas that we think should be prioritized in the response, kind of the rollback of NTD programs after COVID-19. Just communicating model-based results like these, it's very hard to communicate how variable there is. We sort of present scenarios where things look very regimented, but we know this is a really interesting trial for trachoma, where villages were given the same intervention and infection levels were very different in the different villages when they went back. So we know there's going to be a variable response. So when we're trying to give guidance on what the impact is of COVID-19, we have to accept all of those uncertainties in our models. But for us, on top of all of the epidemiological variability, the biggest problem for us in providing projections for the impact of COVID-19 or the impact of any intervention is that we know the estimates of coverage for these diseases of who's getting treated are highly uncertain. We don't really know who is or isn't receiving treatment round after round. And we don't know how COVID-19 has changed the behavior of both the distributors as well as the treated populations. We don't know how surveillance will have changed. We still have uncertainties about spatial heterogeneity. We don't have good estimates of the relationship between infection and morbidity. And we don't know if these new innovative strategies will be implementable. Nonetheless, I feel that the modelling is informative, but it just needs to be acknowledged that there are some clear uncertainties about these diseases. And in general, for neglected tropical diseases, there has now been an expanding discussion, as was described by previous speakers at this meeting, about how to make health systems more robust, to really consider whether NTDs can be that marker for reaching the final mile and how it can maintain that, and how these treatments can be integrated into health systems. And I think this is my final slide. So proposed recovery strategies, which we modeled, for example, twice or 3 or 4 times a year strategy, they will require empirical evaluation before they can be widespread rolled out. But in some populations, there is the opportunity to actually accelerate progress for these diseases. So COVID-19 has driven some innovation in thinking. But, if these programs are really going to come back strong, and they have come back in many, many settings, but we don't fully understand how strongly they have come back, we're going to need more innovation, particularly if there's a reduced funding landscape. And just for us as a consortium, we're working with ESPEN to provide modelling analyses to support subnational decisions. And that's a really challenging and interesting area. So I look forward to speaking to you about that in the next few years. But thank you very much. I'll stop there.
Thank you, Deirdre. Very insightful. Be sure to add your questions for Deirdre or any other panelist in the chat. Our final panelist for this session is Professor Ben Lopman. He is Professor of Epidemiology and Environmental Health at Emory University Rollins School of Public Health. He's an infectious disease epidemiologist with a research focus on vaccines and enteric viruses. The title of Ben's presentation is on the screen right now. Over to you when you're ready.
Terrific. Thank you. Thank you, Yang, for the introduction. Thanks to you and the other organizers for the invitation to be part of this workshop. Really delighted to to take part. Unfortunately, I haven't been able to join the other sessions, and the reason for that is the EEID conference is occurring at the same time here in Atlanta. We're hosting the meeting right now at Emory, which I've been a part of, and in fact, it's given me some pause to think about some of the topics I want to dig into a little bit today, which is that, you know, as we're coming back and having some more interaction, more contact, more opportunities for transmission. You know, we're doing this in the post-COVID or maybe peri-COVID world. That meeting, the EID meeting, is smaller than it has been in the past. We're wearing masks. We're not eating so much together, eating outside. And the point is that, you know, I think the way in which we're having contact is changing, and that may have implications for endemic infections, including vaccine-preventable diseases. And you know, this workshop comes at a great time. I've actually been thinking about this exact issue in some detail. We just wrote a perspective piece that will be out soon on, you know, the potential paths of some endemic infections as contact resumes. And I'll talk about some of that in a moment. So I guess let me just lay out kind of my thesis, and this really builds on what we've heard in this session and what I think has been discussed in previous parts of the workshop and yesterday. And you know, the first idea here is that, you know, the pandemic has clearly disrupted population immunity, decreased population immunity, increased the susceptible pool for many endemic infections, including vaccine-preventable diseases. And the second point, I think, is something I want to add some nuance to in my talk, is that human contact has been altered in ways that I think will affect endemic infections for years to come, really. And the maybe third point, and this will, you know, be a kind of jumping off point from what others have said, is that in addition to the vaccines that we have now, I think, you know, there's been some real innovations, of course, around thanks to COVID vaccines and vaccine development. And I think a real kind of golden age of vaccines is on the horizon. And so we should be expanding our view of what we consider to be vaccine preventable diseases and see some of these challenges as opportunities. So we discussed that first point, and something that, you know, has been touched on already in this session, and I gather yesterday as well, and that is, you know, how the susceptible pool has been increased by non-pharmaceutical interventions, et cetera, because of COVID for other endemic infections. So this is a figure from this perspective piece that's forthcoming that I mentioned a moment ago that worked on with my colleague, Kristen Nelson here. And this is, these are actually data from Germany, from the Robert Koch Institute. And the reason we're use this data source is that there's a really nice integrated federal surveillance system in Germany run by RKI. And yeah, so you can just see these really dramatic reductions. I know this has been discussed for other pathogens, but I think there's a few things I want to kind of draw out here. Is, you know, these reductions in human contact that occurred from the pandemic have really substantially impacted the circulation of other infections, right? So most kind of directly transmitted infections fell to virtually zero in, you know, early 2020 and 2021 amid those lockdowns. Sorry. And you know, some of these declines may have been because of gaps in reporting. We think these, of course, mostly reflect real reductions in disease incidence. And you know, as restrictions have been relaxed, some of these have resumed, some shift to seasonal patterns, et cetera, but they've really yet to return to pre-pandemic levels. And the point I want to make here, and to, sorry, I'm looking for my cursor. You're seeing my screen without the speaker notes, correct?
Correct.
Okay, great. Just making sure I'm pointing at the right thing. So, we see very different types of infections, right? So flu is a not an immunizing infection, but still has been at very low levels of circulation. RSV had this resurgence. We can consider it immunizing in some respects. Measles, which is an immunizing infection, of course, and also vaccine preventable, has been sustained at very low levels. Rotavirus is a vaccine preventable infection. And you may not always think about it as directly transmitted, but I think it actually demonstrates a lot of those kinds of patterns. And although it's not immunizing, in some ways it sort of behaves that way. But we're still seeing a resurgence for rotavirus that we're not seeing yet for measles, for example. And other things like salmonella, which have a similar syndrome, cause a similar syndrome to rotavirus, have not been impacted by the pandemic. And this is because it's not a directly transmitted infection. The syndrome may be similar, but the transmission process is very, very different. Okay. And I want to kind of hone in a little bit on one particular pathogen that's been of interest to me for a long time, and that's norovirus. And although it's not currently vaccine preventable, there are vaccines in the pipeline. And I think it's a nice kind of demonstration of some of the complexity and the nuance about the impacts of the pandemic and the potential for resurgence. So this is a figure from CDC's surveillance system called Norostat that records norovirus outbreaks in the United States. And you can see the shaded region, the kind of pre-pandemic norm. The dashed line is 2020 and 2021 season. So there was very little activity, bit of an increase in 2021, and then low levels of activity. And now kind of a resurgence, but at kind of essentially kind of pre-pandemic levels for norovirus at least, and a delayed start to the season, a really substantially delayed start to the season. So that's what we've observed so far. We did this analysis, was led by Alicia Cray, and she showed that really this reduction was consistent really across all of the rapidly reporting states, and this work was done in collaboration with our colleagues at CDC. So really, substantial reductions wherever reporting was done in a timely way, and they were contributing to this surveillance system. And interestingly, for norovirus is this very common cause of diarrheal disease, gastroenteritis, causing outbreaks, and major reductions across all settings. Hospitals are a place where there's a lot of norovirus outbreaks, and although there was a reduction, there was a smaller reduction than compared to daycare settings or colleges, for example, which were essentially shut down. And of course, hospitals increased infection control during the pandemic, but still, of course, had to continue operating. So interesting to see that there were smaller effects in those environments. So the point I want to make here is that it's clear that many infections, directly transmitted infections, including vaccine preventable diseases, have had slower incidence, leaving this immunity gap. Others have touched on this already. And this immunity gap is driven by people who would have been infected but for the pandemic and all the non-pharmaceutical interventions. One thing I haven't talked about, but others have alluded to, is this temporary fall in vaccine coverage. This is maybe a particular issue for rotavirus. It seems to be about a 10% reduction in high-income countries, at least in the United States. The specific problem for rotavirus vaccines is that there's a strict cutoff when the vaccine can be administered, at least in most countries. So you don't really have the option of kind of catch-up campaigns to revaccinate these kids who were missed. And so that also leaves this immunity gap specific for that pathogen. So the second piece of this that I want to talk about is how human contact has been altered. And, very clear that during the pandemic, there were these, during the kind of lockdown phases, these very dramatic changes in human behavior, right? And this is this image from South India, and mid 2020 during this extraordinary nationwide lockdown, what would otherwise be a teeming, busy street. But what I want to argue is that, despite the end of lockdowns and the relaxation of non-pharmaceutical interventions, there's been we think we're yet to see a return to the pre-pandemic normal. The world over, really, at least for the places for which we have data. And I think it may be a long time before there's a return to normal, or maybe in a new normal, this kind of new status quo of human interaction. And it may have really wide-ranging impacts on the epidemiology, burden, control of infectious diseases, including endemic diseases, vaccine-preventable diseases that have been with us for ages. So I want to share a little bit of data from the US that we've been collecting about contact patterns. This is a study that actually was, we intended to set up pre-pandemic. It was meant to be a study on contact in regards to flu transmission, specifically in workplaces. And for that reason, because of the focus on workplaces, we called the project Corporate Mix. We had a number of these corporate partners whose employees participated in these contact surveys about how they were having interactions. This was work that was funded by CDC, again, with the intention of understanding flu transmission, but we quickly transitioned to think about COVID. And we actually also have a global project, kind of sister project to this, we call Global Mix, which is collecting data, like the Polymod study, but in low and middle income countries. And I'm not going to share any of that data right now, but wanted you to be aware that during the pandemic, we are collecting mixing data in Mozambique, Guatemala, India, and Pakistan. It's just not quite ready to share yet. So here's what we've observed in terms of contact patterns over the first 4 rounds, which began in kind of during the lockdown period, April, June 2020, and this last round was in November to December 2021. Basically, we observed pretty low levels of contact overall. Overall, we were observing about 5 contacts. Even now, observing about 5 contacts per person. Community contacts, of course, were very low early on, and it increased. Home contacts have, if anything, decreased a little bit as people are maybe spending less time at home and more time in the community. And work contacts increased, from the lockdown period afterwards. But again, one of the things I want to point out here is that we unfortunately don't have pre-pandemic data in this population, but the contact levels are nowhere near what we think they were prior to the pandemic still. Even in our most recent round, averaging 5 to 7 contacts per person. Pre-pandemic, we think that was in the range of 13 to 15 in the US. How people are having contacts is also changing. I'm not going to go through this in detail, but the idea is that people are having longer contacts, more intense duration, more of those contacts being at home, more of those contacts are repeated with the same person. So that's really important in thinking about our kind of social networks. And more contacts are conversation only as opposed to physical. And so even if the numbers of contacts are increasing, the character of those is changing in ways that might be really important for the long-term trajectory of infectious diseases. This is data from the UK, from the COMIX study, which is, I show these kind of 4 rounds that we performed in the corporate mix study. COMIX has been this ongoing survey in the UK about contact patterns. And again, I just think this supports this point that although contact patterns are changing, they're still far below what we think were the pre-pandemic levels. So this is, data from another country. And I don't have the numbers to the slide to share on this, but contacts we still think are less likely to involve physical touch and risk. Masking, although masking, of course, is reducing really substantially, still in most recent surveys, about 30% of the US population reports routinely masking at work. 25% of children are reporting to be still masking at school. I think those numbers are, well, are decreasing, but it's all to make this point that even subtle, there may be subtle changes going on that can reduce transmission of endemic infections. So to kind of illustrate this point, we developed a toy model, and here is a cartoon from this toy model to examine this idea that, even if reductions in contact are modest, the impacts on endemic diseases could be quite significant, right? So, many pathogens kind of maintain this fine balance of an endemic equilibrium where, the effective reproduction number it is sustained at close to 1, or at least averages 1 over the course of a year. And that's kind of the definition of endemicity, right? So this figure shows some possible future trajectories of endemic pathogens, following this major reduction and then a partial resumption in contacts, and kind of highlighting what these kind of resurgence or patterns might look like for different types of pathogens. So for a pathogen that kind of confers lifelong immunity, for which there's not a vaccine, we might expect a really rapid increase following resumption of contacts. And, in this kind of toy model here, we're not increasing contacts back to pre-pandemic levels. It's still lower levels than pre-pandemic, reduced by 20% or so. But we still see, still can see a massive, substantial resurgence. The timing of that resurgence is probably would be delayed with vaccination, because you're maintaining immunity in the population both through, through vaccination, which would have persisted even if at lower levels during reduced social contact. But these patterns are different for non-immunizing infection, with temporary immunity, shown in the green line, and even more complex dynamics for seasonal pathogens that don't confer long-term immunity, which, you see these shifts in seasonality and kind of complex patterns bouncing around before reaching potentially a new level of endemic equilibrium, which may be slightly lower than pre-pandemic. Okay. So that was a kind of toy model. I want to actually show now some more grounded examples. And this was some work that a doctoral student, Brooke Lapé, did, looking at these two pathogens that I've mentioned already, rotavirus and norovirus dynamics in the US primarily. So developed two models, a SIRS model for norovirus and an SIRV or SIR vaccine model for rotavirus. We fit the model to surveillance data. And we changed contact patterns based on mobility, and then forward predicted kind of resurgence of these two pathogens under different levels of contact resumption. You can see here the data which we fit to norovirus on the left and rotavirus on the right. Now, we used mobility data as a kind of indicator of contact patterns. This is mobility data summarized by IHME, I think using SafeGraph and other sources. And so, we looked at resumptions at different kind of levels, pre-pandemic, 70, 80, 90%, or 100% resumption in contact. And, one minor point I want to make is I think these increasingly realizing the mobility data is probably not the best indicator of contemporary contact patterns, because it doesn't capture things like masking and other like more subtle forms of social distancing. So here's the projection for norovirus, and essentially what we see is if with 100% resumption in contact, we would see these really major resurgences over a couple of year period after settling back into a kind of endemic equilibrium. As I mentioned before, that's not what we've observed so far. We haven't seen these massive resurgences. And so I think these lower levels of contact resumption, 90, 80%, are probably more in line with what we're experiencing. Right? Turn to rotavirus now. And for rota, I want to just mention kind of one thing about how how the interventions can, of course, disrupt not just how vaccination interrupts not just the disease burden, but also the kind of dynamics of pathogens. Rotavirus vaccines were introduced in the U.S. around 2007 here, right? And you can see prior to vaccine introduction, this very regular pattern. The top line are basically gastroenteritis cases, and the bottom line are rotavirus cases. You see this very regular annual epidemic, annual periodicity that was occurring until 2008. Vaccines were introduced around here, and subsequently, we have experienced a biennial pattern of disease. This was partially predicted by some models, including work by Ginny Pitzer, and has really been borne out, right? You can see this every other year, a kind of mini epidemic that occurs following this buildup of the susceptible population, big enough to sustain at least small epidemics. So it's kind of in this context that now we're further disrupting rotavirus dynamics in the U.S. with the effects of COVID. And here's the kind of model projections for rotavirus, and you see these kind of biennial patterns pre-vaccine. This major drop of incidence following the pandemic, and then our projections of what could happen subsequently. Again, it could be a major resurgence if we had contact patterns resume to pre-pandemic levels. But again, this is not what we're seeing. We are seeing the beginnings of an uptick for rotavirus. And so I think, over the coming years, we might see these more complex patterns with, resurgences, different sizes of epidemics occurring from year to year, different levels of burden on the healthcare system, and also potential for, reduced levels of disease. And I think that presents a kind of real potential opportunity here, right? In terms of, this point that Jess brought up earlier about kind of building back better. What if we can have higher levels of vaccine coverage? This is a real opportunity to kind of double down and enter a period of lower endemic equilibrium for these pathogens. And kind of final contrast I want to make between these two bugs. They cause very similar disease in a sense, similar syndrome, rotavirus and norovirus, is how the population susceptibility will differ between these two pathogens, mainly because immunity to norovirus is all naturally acquired from infection with the virus, whereas immunity to rotavirus is both naturally acquired and acquired through vaccination. So, population susceptibility, you can see this figure here is showing population susceptibility relative to the pre-pandemic period. Each of the line represents kind of the different levels of contact resumption. And what you see is that for norovirus, population susceptibility increases kind of much more quickly than it does for rotavirus. And this is partly because immunity can wane to that pathogen, and also because we're not having any immunity acquired through vaccination. Contrast that with rotavirus. And so I think that's underlying these different dynamics of what we're modeling and what we're beginning to observe. Okay, so final point I want to make is that I think we, in this context, it's also important to think about the opportunities that are presented by kind of a new golden era of vaccines that is on the horizon. I've talked a bit about these two pathogens, norovirus and rotavirus. We have a vaccine for rotavirus. Vaccines are nearing the market for norovirus, and I think that's going to be true for a lot of potentially vaccine-preventable infections. I'd argue this is a really exciting time in vaccinology. There's so many vaccines are in the pipeline. And if you doubt that, I suggest you go check out the website of any company that holds mRNA technology. They're talking about, so many vaccines are the potential to be brought to market quickly. combination vaccines. I think that's something that's very exciting for, for thinking about, multiple etiologies presenting in a similar syndrome, like diarrheal diseases, right? People are, I think, from a public health point of view, interested in preventing the syndrome, the disease, rather than individual pathogens. And so it's really, really attractive to be thinking about combination vaccines. So I've just listed a couple of vaccines here, and it's kind of selective, highlighting those that are either I'm working on or others at Emory. We have a group that's forming called the Emory Alliance for Vaccine Epidemiology. And this is just kind of a selection of pathogens that have kind of established vaccines, recently introduced vaccines, or those which are in the pipeline and are either in late stage 2 or stage 3 trials. So, again, referring to this point that both Jess and Deirdre made, that, we're at this point of low incidence for a number of these pathogens, either because of honeymoon periods coupled with suppressed levels of contact. And there's kind of a real opportunity here to reach kind of lower levels of endemic circulation, or maybe even endemic, local elimination for some pathogens. There's a real kind of opportunity if we can double down. So the kind of last point I want to make, this is a picture from a review that some colleagues here at Emory and I published in Science a few months ago, and kind of just outlined how the questions that were most relevant during the pandemic changed, right? Started with questions about, can the virus SARS-CoV-2 be contained? Then we asked about, which non-pharmaceutical interventions are most effective, broadening to kind of biological and natural history questions. Can reinfection occur? Is SARS-CoV-2, continuing to adapt? How is it escaping population immunity? And, now that we've reached this, I'm not going to say post-COVID world, but peri-COVID world, I think it's time to start asking these questions that have been addressed in this workshop about, what are the effects on other endemic infections, specifically vaccine-preventable diseases, and what opportunities does this present? So some concluding thoughts. This lower incidence during the pandemic left immunity gaps, increases in susceptible population for endemic infections, including vaccine-preventable diseases. The resurgence patterns will depend on a number of things, like the specific natural history of infections, the degree of vaccine-induced immunity, including lower levels of immunization from the pandemic, and again, this point about contact, right? The number and specifically the characteristics of our contacts going forwards. And amid this complexity, there's all these new vaccines in the pipeline, which I think present a real opportunity for us. So I'll finish there by acknowledging our research group who did a lot of the work that I presented here today. Our collaborators really across the world, and range of funders who support this work. So with that, thanks again for the invitation and for your attention.
Thank you, Ben. Thank you for a great talk. And thank you for everyone who have added question to the chat. So I think we have a little bit of time to accommodate some of the questions. I think what I'm going to do is maybe post one question for all of our panelists. And then maybe if we have more time, we can have a single question for each person. So I think the overarching question that I think our audience would like to pose for all of our speaker is about the scales, either temporal scales or spatial scale. Is there a time horizon and spatial scale for coordinated response for them to be most effective? And generally in your practice, how are these scales decided on? I think maybe we can start with Jessica, because you went first.
Well, it's a really interesting question, and it's a very hard question. I mean, I think there's a very easy answer, which is that faster is better. And I think there was, so my colleague Matt Ferrari has done a lot of work showing that outbreak response is actually, it was thought to be something that was likely to be too slow to actually mitigate the burdens of such pandemics, but in actual fact, it still gains you lives saved. The question of how much coordination, so the baseline is just get out there fast, right? But of course, life isn't like that. And much of the work that I referred to in the last section of my talk on coordination across countries was explicitly, so this is Amy Winter, explicitly thinking about how much time you've gained. So for example, if you start in a country which has a very effective program, then you might have 16 years to play with where you're expecting very little incidence. But in countries with extremely high birth rates, and where the susceptibles are going to replenish very quickly, you might only have a couple of years. And so you should be designing your sort of, if you were in a world where you could design a global program, you should be designing around sort of buffering around those places. And you can start to get quantitative around those questions within the limits of what we can do. So I think you can certainly make up a hierarchy of how, or at least a sort of bound the problem of how sensibly one might approach things. And then of course, there's the interesting question of, although we live in a hyper-connected world, there are likely to be greater connections within regions, and so coordination within sub-Saharan Africa is likely to be important over and above sub-Saharan Africa doing the same thing as Mongolia, or so this is a fairly obvious statement, but that's what I have.
Thank you, Deirdre.
Yeah, Jess has covered a lot of good ground, really. I think with the diseases I work on, most of the epidemic growth rates are very slow. So that would suggest that you don't have to do everything quickly. But the problem is momentum and political will. And, it's really, if these diseases get lost again, that we won't have good enough surveillance to know what's going on. And in 10 years' time, we'll have a really big problem. The preventable, it's so frustrating, kind of preventable morbidity and some mortality. So I think, we did have a very detailed discussion about what should be prioritized for schistosomiasis myositis to try and make the case that really there's some areas where schistosomiasis, this waterborne helmet, really causes serious morbidity in children. Can we prioritize the places with the high prevalence? But because these are sort of cross-national problems and there are so many subnational things going on, it's really hard to really drive that kind of prioritization if you're not involved with the national government conversation. And so I think it's important to provide tools to help countries, national governments and researchers and everything, and within your own country is the only place really you can have that conversation. And I think we've all experienced that. Lots of us have been pulled into COVID-19 modeling. You could really only successfully have a conversation with your own government. And then it's a variable quality, right? But so I think, as a global community working on global diseases, we need to understand that decisions are made at that level. And then that's where your spatial question comes in. It's really at what spatial aggregation a country is able or willing to act. Because sometimes they can't prioritize one area over another because politically that's just not tenable because it's seen as withdrawing interventions from another area. So for me, it's a very political answer. Basically, I think politics determines a lot of the scale and speed of response.
Definitely. That's a really good point, Ben.
Yeah, thanks. Really not much to add to what Deirdre and Jess already said. The only thing I think worth considering is the specific infections that you're working on, right? If for these classic kind of childhood diseases, infant immunizations, time really is of the essence. I mean, you're really working with a very small window, and it's so critical for some of these classic, the early childhood infections to vaccinate kids at a very, very young age. And so it's really important to get immunized on the EPI schedule. And I mentioned, the particular issue for rotavirus vaccines that most countries will not vaccinate kids after 8 months of age. So time really is of the essence. So the temporal piece is really critical.
Thank you. I think I was still like, since it's really great that we have 3 amazing speakers on the line, I'm just, although we're like 1 minute left, I'm just going to go ahead with the individual questions. And if we can just kind of manage our answers to be a little bit shorter, that would be really appreciated, so we can have a little bit more time for people between talks. So first of all, for Jessica, I think your talk have draw a lot of links to some of the talks that we have heard yesterday. And I think one quote that like really resonate with me is just, we're not just building back, we want to be building back better. And then you were also talking about essentially strengthening of the healthcare system is one thing that could provide solutions to many different things. It has a lot of different positive externalities. I'm just kind of wondering if you could go into a little bit more details about, like, for example, in that specific case studies that your team have done, what aspect of improvement in the healthcare system do you think has most significantly contributed to better vaccination outcomes, etc.?
So this is a great and extremely hard question. And I think one of the challenges which has come up is the challenge in actually evaluating these health system strengthening strategies, right? Because you tend to do everything all at once. So it's very hard to disaggregate what's actually having the impact. There's a case to be made. Andres Chitarona has a paper on this, saying that because they're so hard to evaluate, people tend not to go for them. You know, you like the silver bullet, you like the single vaccination program, etc. So in a way, there's a distraction in the simplicity of the things you can plug into a randomized controlled trial very easily. So the answer is, it's hard to pin it down to a specific aspect of it. And I think in a way, you know, the boring things like a well-funded health system, trained personnel, and everything through to probably sick leave are important pieces in how we build back better. How you evaluate the relative benefits of one or the other, I'm not sure. Sorry, that was long.
Thank you. And then for Deirdre, I think you talked about mass drug administration. So yesterday we kind of covered topics around vaccine confidence. And I think for many people, especially young adults, their experience with the vaccine mandate and a lot of the vaccine news in this era have given them like a very mixed feeling. I think Heidi was talking about, just because individuals have received vaccinations does not necessarily mean that they're not vaccine hesitant. So I'm just kind of wondering if, because you talk a lot about access and willingness to receive treatment, I think in the specific context of we have collectively experienced this pandemic, how that changed, or do you anticipate seeing any differences in terms of like willingness to receive treatment, and what might be the intended solution for that?
Yeah, I think I'm not an expert on it, but yes, there's not a huge amount of published evidence, I don't think yet, but we have an expectation that it will have changed people's response to healthcare interventions, and that will include all healthcare interventions. So there are anecdotal reports of people obviously being resistant to people coming into the village who might bring COVID, but also that the treatment was really a COVID vaccine. And, you know, and we've seen how damaging rumours like that can be. And I think, yeah, I mean, I feel I'm going to keep my answer short because I'm not an expert. I think it's a real challenge, and it needs some really innovative thinking, and in that integrated healthcare thinking as well.
Thank you. And lastly, for Ben, have you studied the herd immunity level needed in light of the changes in context for diseases like measles, for example?
Yeah, no, that's a great question. I mean, the simple answer is no. We have not directly, but you know, in principle, the kind of herd immunity threshold would decrease as you're reducing the basic reproductive number with lower levels of contact, and so the herd immunity level would decrease. the focus of my research is really on non-immunizing infections, for which the herd immunity threshold is a much slipperier concept, and so we don't really think about elimination of rotavirus, for example. But I think the principle holds that you have lower levels of disease, and there's an opportunity there to increase vaccine coverage and have even a bigger impact. Thanks.
Thank you. As the chair of the session, I'm just going to enact my power and ask Ben another question, because I'm personally really curious. How does the US contact result that you have shown compare to stuff like Comex? Because I would imagine like US and UK have, to a degree, some cultural similarity. I'm just kind of wondering, have you guys looked into any of these comparisons?
Yeah, it's a good question. Yeah, it's a little hard to make direct kind of comparisons between our study and Comex. I think the overall levels of contact are quite similar, like the numbers of contact reported have been quite similar. We also haven't seen like huge changes in the US, like in the UK, nowhere near pre-pandemic levels, at least what people are reporting. One big difference here, I didn't show this, but we're collecting information on masking behavior. Actually, in another study, not the corporate mix study that I showed, masking behavior and contact patterns, and it just lines up so well. It's so closely correlated with political affiliation in the U.S. And I don't know if that's been reported in Comex, but it's not my impression that things fall so clearly along political lines in the UK for these kinds of behaviors like they are in the U.S.
Yeah, thank you so much. I think that will be a wrap for our conversation today. This has been a great discussion, and I wish we could keep it going, but we do have a great keynote speaker that I know you will want to hear, Dr. Raji Tajudeen from Africa CDC. He will be joining us in about 14 minutes time on this link. So if you're interested, feel free to just stay on the line. And with that said, thank you to all of our speakers again for their time and sharing their knowledge with us. Thank you. Nice meeting you.
Thank you.
All right, I think we are ready to get on with our keynote since Dr. Tajudeen is here.
So welcome back everyone from the break. We're very excited to have Raji Tajudeen with us for a keynote presentation today. Dr. Tajudeen is a fellow of the West African College of Physicians and the African Public Health Leaders Fellow of Chatham House. He has over 20 years of experience in child health and public health and has worked in many different settings in the developing world, including Nigeria, Saudi Arabia, Liberia, Guinea, Sierra Leone, and Ethiopia. Taj is currently the head of Public Health Institutes and Research of Africa CDC. He coordinates the establishment and strengthening of national public health institutes across the 55 African Union member states. He oversees the establishment of the 5 Africa CDC regional collaborating centers. He coordinates the Africa CDC Institute for Workforce Development and oversees the Continental Public Health Research Agenda. We're grateful to him for taking time from that awesome set of responsibilities to speak to us. So please start whenever you're ready.
And Dr. Tajudeen, just in case you didn't know, you are muted.
Hello, can you hear me?
Yes, now
Hello,
we can.
thank you.
All right. No, thank you for the opportunity to be part of this. I bring you greetings from the Africa CDC leadership. And I think for us, this particular topic, that's vaccine-preventable diseases in a post-COVID world, is critical to what we do as Africa CDC. Just for a point of emphasis, we know that the World Health Organization declared the COVID-19 pandemic, declared the COVID-19 outbreak pandemic on March 11, 2020. And this is just shortly after Africa recorded its first case on February 14, 2020. And as of today, fast forward, Africa has recorded close to 12 million cases of COVID-19. We've recorded over 250,000 deaths, and of course, more than 11 million cases have recovered. So just to say that more than 90% of our cases have recovered. But what is sad here is the fact that as of today, we have only been able to vaccinate 17.2% of our population. And of course, the reason for that is very obvious. And we know that that particular reason also has huge implication on routine immunization, huge negative implication on routine immunization. Let me use this opportunity to also share with you what we did as Africa CDC as this COVID-19 pandemic begin to evolve and affect our continent. Shortly after the first case of COVID-19 was reported on the continent, Africa CDC set up what we call a continental task force to address the coronavirus. Much more importantly, that task force set up different technical working groups. And then very important as well, a couple of guidelines were also developed to support our member state to respond to this COVID-19 pandemic. And one of the guidelines was actually to guide our member state on how should they continue to run those essential health services, including immunization, especially childhood immunization, which key into what we are discussing here today. Because we learn a lot from the Ebola outbreak in West Africa, whereby most of our childhood immunization dropped significantly. For instance, we knew that over the 3 years of Ebola outbreak in West Africa, the measles vaccination rate dropped by about 25%, thereby reversing the gains that the hard-earned gains that we've made over time. And of course, what followed was a series of measles outbreak with a lot of grave consequences. So it was in this regard, the Africa CDC issued a guideline to support our member states on how best, to continue to run those essential services, especially childhood immunization, because we knew that not doing that, we risk most of our population dying from those essential, dying from lack of those essential health services like malaria prevention, like measles, like TB, like polio, HIV, AIDS. So we issue a guideline on the need to continue to run all those key services. Fast forward, we have seen the way the pandemic has disrupted those essential health services, despite the measures that were put in place, to forestall or to prevent this. And one of the key areas that was severely disrupted include the immunization-related activities. Of course, we know that disruption ranges from 16 to 57%. And this was largely in the low and middle income countries, largely in our setting in Africa. Specifically, the COVID-19 disrupted the routine immunization. It also disrupted immunization in response to outbreak, like we've seen the way, polio has affected some of our member states, and the response to that, which is essentially underpinned by mass immunization or supplementary immunization, has also been affected by the COVID-19 pandemic. We have also seen postponement of immunization campaign in several settings. And of course, we have also seen the postponement or the suspension of surveillance for our vaccine-preventable diseases. So all these has led to heightened or increased risk of vaccine-preventable diseases, with that possibility of outbreaks, as we have seen with polio, as we have seen with measles in some of our settings, DR Congo, Mozambique, Malawi, and so on and so forth. Again, ladies and gentlemen, this disruption has affected virtually every region on the continent of Africa. No member state is spared. And consequently, millions of our children today, as a result of this COVID-19 pandemic disruption of our routine immunization services, are at the risk of devastating but preventable diseases. So going forward, Africa CDC will like to see what we call a prompt resumption of immunization activities, one, to address some of the losses we have encountered as far as the COVID-19 pandemic is concerned, and two, to be able to get to what it used to be, before the pandemic, and three, to continue on the trajectory of improvement of the successes that were reported before the COVID-19 pandemic. And the only way to do this is to put in place effective and efficient catch-up strategy through combination of enhanced routine immunization services, bring back those immunization campaigns that were suspended because of the COVID-19 pandemic, put in place those surveillance activities that will allow us to track those vaccine-preventable diseases, so that we are able to quickly identify those hotspots and deploy immunization activities as much as possible, because this is the only way we can reduce the risk of vaccine-preventable disease outbreak on the continent of Africa. Furthermore, Africa CDC want to see integration of primary healthcare system as part and parcel of our pandemic response. Because in a situation whereby we begin to see pandemic response as separate, and we begin to move resources from our primary health care towards those pandemic, we leave us exposed, and we leave our kids or our children at risk of vaccine-preventable disease outbreak. And Africa CDC continue to call for a new public health order, to guarantee our health security, because we believe that both health security and primary health care system or universal health coverage are two sides of the same coin. A new public health order that is underpinned by one, the need to strengthen our public health or health institutions. Our primary healthcare development agency need to be strengthened. Our National Public Health Institute need to be strengthened. Our National Reference Laboratory need to be strengthened. Our surveillance system need to be strengthened, because this is the only way we can have in place a resilient health system that can withstand any shock. And I think going forward, this is the only way we can build better and stronger from the COVID-19 pandemic. Number two, as part of our new public health order, is continuing to increase and expand our health workforce on the continent. Workforce and the right number, workforce in the right distribution, workforce in the right skill set. You know, this only way, excuse me, this only way that will ensure that when the next pandemic strike, we are not going to be moving staffs away from our primary healthcare system. We are not going to be moving staffs away from our routine immunization program. We are not going to be suspending our immunization campaign just because we want to respond to a pandemic. So scaling up, expanding our health workforce development on the continent is critical. And in this regard, our head of state and government have actually tasked us to put in place health workforce task team that will sit down and come up with a framework that will allow to address that critical gap as far as health workforce on the continent is concerned. Gap in terms of our community health workers, because we know today that our community health workers are in short supply. In 2017, our head of state gave us that mandate to come up with 2 million community health workers, so that by year 2020, we are going to have one community health worker to every 500 people on the continent. Today, we are far from that. You can imagine the role of community health workers in routine immunization. Imagine if you have the right number of community health workers during this COVID-19 pandemic, I'm sure we'll be able to sustain our routine immunization services and will not have any cause to begin to crack our brain on the potential or the likely risk of vaccine-preventable disease outbreak due to disruption caused by the COVID-19 pandemic. We also know that our epidemiologists are in short supply. Let's look at frontline epidemiologists. What we currently have today on the continent is just 5,000 frontline epidemiologists. And what we need for a population of 1.3 billion is 25,000. So the gap there is around 20,000. So we need to find a way to build that gap, because all these will contribute to strengthen our primary healthcare system, and it will also contribute to preventing those vaccine-preventable disease outbreak. And as much as possible, it will allow us to continue to run the essential health services, even in the face of any pandemic or epidemic outbreak. Number three, we need to build our local manufacturing capacity. Local manufacturing capacity for vaccines, for therapeutics, for diagnostics. Allow me to unpack building local manufacturing capacity for vaccines. Because again, one of the reasons for this disruption of this campaign is the fact that most of these vaccines have to be imported. Most of these vaccines are competing for resources with the COVID-19 response. So if you have our own local manufacturing capacity on the continent, we believe that to the barest minimum, we will reduce this disruption in our routine and vaccination campaign. Today, as a continent of 1.3 billion people, we only produce 1% of what we need as vaccines. 1%, I repeat. 99% of what we need is imported. So tell me, how can we be resilient as far as vaccination in general is concerned? So Africa CDC has set up a very ambitious target to shift that needle from 1% as we currently have it to 60% by year 2040, because we believe that that's the only way we will be addressing some of these vaccine-preventable diseases, you know, especially in the context of any outbreak or any epidemic or pandemic. Number 4, partnerships. Very, very important. One of the things we did when the COVID-19 pandemic struck was to actually talk to all the partners who are supporting other programs on the continent. Vaccines, malaria, TB, HIV, that please do not shift resources from those programs to COVID-19 pandemic. Let's continue to run those programs, because eventually, if we do not manage that space very well, we will have what we had in West Africa in 2014, whereby most people end up dying from lack of those essential services than even the Ebola itself. So we didn't want history to repeat itself. But despite that, we still had a lot of disruptions. So I think going forward, we need this sort of partnership, that will be able to sit down and agree on what should be our priorities going forward. So this is what we call a respectful and action-oriented partnerships. And for a cross-cutting enabler that will allow us to actualize this new public health order is the importance of domestic financing. Because all these I've mentioned will not be possible without mobilizing resources locally, because that's the only way we can have a sustainable investment in our primary health care system. That's the only way we can have a sustainable investment in our routine immunization. That's the only way we can guarantee universal health coverage for us, for all. And that's the only way we can put in place a resilient health system. Ladies and gentlemen, before I finish, we continue to advocate for integration of the COVID-19 vaccination within our primary healthcare system, so that whatever platform we have put in place to drive the COVID-19 vaccination will continue to strengthen what we have in place for our routine immunization. We continue to strengthen what we have in place for our supplementary immunization activities. We continue to strengthen what we have in place for our vaccination campaign. So in essence, what we are saying here is that let's build on the gains of the COVID-19 pandemic. Let's build on the successes. Let's build on the resources that the COVID-19 pandemic has mobilized to bring us out of this COVID-19 pandemic, to strengthen the routine immunization campaign and supplementary immunization activities that we have in our respective member states. So on that note, I thank you, and I look forward to the outcome of this particular important meeting. Thank you, and over to you, Chair.
Thank you very much for that thought-provoking talk. We've got some time for questions, and people should be used to this by now. If you add them to the chat, we'll get to them as we get a chance. So as chair, I'm going to take my prerogative to start off with a couple of questions. First of all, we've heard some talks about the difference between simply reinstating a vaccination program that was already existing and then having a campaign that allows you to catch up and reach the people who were missed during the past 2 years. Do you think it will be possible to have these catch-up vaccination campaigns?
No, thank you, Stephen. So we all know the role that vaccination has played. In fact, we describe it as the single most important public health intervention of all time, as far as the continent is concerned. So given that, we have to put everything possible to make sure that we implement a catch-up strategy, to plug the gap, that has been created by this COVID-19 pandemic. And that is where we have to sit down with all our partners. That's why we have to sit down with all the UN agencies who are responsible for vaccination on the continent, because we need to address that gap. If not, we risk vaccine-preventable disease outbreak on the continent. And you all know that it takes It costs a lot more to address an outbreak than to prevent it. So I think it's in our own best interest to put resources and address that particular gap, come up with a catch-up, because that's the best strategy actually in any, when you are coming out of any epidemic or pandemic outbreak. You need to catch up on the ground that you have lost, and the reinstating the routine vaccination, again, we cannot do otherwise. We don't have an alternative choice, because we know that the number one killer on the continent of Africa today still remain those under 5 deaths. And we have made significant gains. So we don't want to lose those gains. You don't want to see those gains being eroded overnight due to lack of planning, due to lack of making what I describe as smart investment. So I think it's in our own interest to invest in terms of catch-up, vaccination, to take us to where we were before the COVID-19 pandemic, and put in place a very strong routine vaccination. And a lot of resources has come through with the COVID-19 pandemic. So let's tap into that opportunity, and build a very strong routine immunization for the continent. Over, Stephen.
Thank you. Thank you. Can you expand a little more on the barriers to recruiting healthcare workforce? And do you think there are ways that other regions can help you build and train the epidemiologists that you were asking for?
Again, thank you, Stephen. I mentioned that in 2017, our head of state did issue a declaration or a decision asking the entire continent to come up with 2 million community health workers minimum. And one of the things the COVID-19 pandemic has done is to demonstrate the importance of community health workers. Because one of the good things that we did as Africa CDC was to support our member states to deploy community health workers. Because we know that ultimately, the control of this COVID-19 pandemic will depend on a very strong primary healthcare system. And we know that the cornerstone of any strong primary care system remain the community health workers. So in terms of what others can do, I think we can play a lot of role as far as advocacy is concerned. And we have some couple of tools that will allow us to do that. That declaration of our our head of state and government in 2017 is a very strong and a good advocacy tool that we can use to mobilize resources as far as community health workers are concerned. When you look at epidemiologists, let's look at the front line. As I mentioned, what we need as a continent of 1.3 billion people is 25,000. What we have today is 5,000. So the gap there is around 20,000. So we need all the resources, in terms of financial and human resources to address that gap. And we know that we have a couple of, institutions in the global north who have what it takes, to support this agenda. So this is a time, for them to see the need, to support the African Union, support the Africa CDC to address some of this gap. Again, it's also in the best interest of everybody. We are talking of a new pandemic treaty. We are talking of the gaps in IHR. All this cannot be plugged without adequate workforce. It's not possible. Even the routine immunization itself, because one of the reasons why our routine immunization has suffered is because people have to be taken away from routine immunization to respond to the COVID-19 pandemic, because the number is not just there, So this is a perfect opportunity for us to see the importance of scaling up that number, to see the importance of ensuring that that number that we have is also adequate. They have the necessary skill set. And in terms of distribution, we also get it right. And a very perfect platform to provide all this support still remain the regional mechanism like the Africa CDC, because we know that we have member states who are different stages of development. And what Africa CDC is able to do is to ensure that there's equity in the allocation of these resources that are coming through. So I think for me, this is what I will expect from partners. Support us in terms of resources, human resources, technical support, financial resources, the digital platform, to train all these essential health workers. Over. Excuse me.
Thank you for that. Could you describe maybe some other resources and opportunities you see that were developed during COVID? Things like cold chain infrastructure or other kinds of public health infrastructure that you'll be able to apply to other vaccine-preventable diseases?
All right. No. Thank you, Stephen. So currently, as African Union and Africa CDC, we have what we call the Saving Lives and Livelihood Program. Now, this program is to support our member states to ensure that we get to that 70% target of COVID-19 vaccination as set by WHO. And through this program, we are working with a couple of partners. The most notable among them is the MasterCard Foundation, who has provided 1.5 billion USD to this partnership to scale up vaccination, that Saving Life and Livelihood program. And through that support, other partners have also come on board, like the French Development Agency, the US government, the Skoll Foundation, the Rockefeller Foundation, to provide support. Now, within the Saving Life and Livelihood program, we have 8 core activities that has direct and indirect bearing on vaccination. One of the core activities there is the logistics support, building cold chain infrastructure, which we are doing together with UNICEF. So today we know that the gap as far as that space is concerned is quite critical. But the COVID-19 pandemic, on the flip side of that, has provided a perfect opportunity to fix that. So we should not allow this opportunity provided by COVID-19 pandemic to go to a waste, because a lot of mapping exercise has been done. A lot of readiness assessment has been done. So we know where the gaps are, and we know what it will take to fix those gaps. And they are all out there. They are all on the website of African Union, World Bank, and so on and so forth. So it's not left for the partners to work with the regional organizations, to work with our local implementing partners, to begin to address that gap. And we believe that the COVID-19 pandemic, as some people call it, the greatest equalizer, So this is a perfect opportunity to use the resources that are coming through the COVID-19 pandemic to address some of these cold chain logistics, to address those COVID-19 vaccination centers, be it fixed or mobile, put in place a very strong capacity, to monitor adverse events for the immunization, put in place a very strong pharmacovigilance. In fact, we're using that same platform to see how we can put in place a very strong genetic or molecular surveillance capacity on the continent, monitor the different variants that are there. It's also a perfect opportunity for us to begin to have a robust discussion along the line of local manufacturing capacity, not just for COVID-19 vaccine, but for other childhood immunization. We know that with mRNA technology, you are able to do a lot of other things beyond the COVID-19 vaccine. But Africa cannot do it alone. We need all sorts of support, technical, financial, and other resources to do this. So, this is a perfect opportunity. A lot of mapping has been done. The result is out there. And the African Union, Africa CDC is also providing a platform for partners to key in and address some of these cold chain logistics, which has prevented a lot of our member states to get to what we call the last mile delivery. as far as vaccines are concerned. The other thing we also need to focus on is on the aspect of surveillance. Surveillance for those vaccine-preventable diseases. I'm sure you will agree with me that with surveillance, what we are seeing in Mozambique, in Malawi, in terms of the polio cases we are seeing there, with a very strong surveillance, we're able to pick those things early, before it gets into the wider community. And at the end of the day, it's in the interest of everybody. Thank you.
Thank you. If you don't mind, we have a few more questions still. So the flip side of that last question would be, do you think the COVID response has created any problems that might show up with other diseases, like vaccine hesitancy? Have people become fatigued with thinking about public health?
All right. No. Thank you. That's a very good question, and a very tough one at the same time. Now, we did a survey with a colleague from London School for Hygiene and Tropical Medicine, the Vaccine Confidence Project there. A couple of surveys, not just once. I think we repeated it some couple of times to understand the COVID-19 vaccine perception on the continent, and also to look at their perception of other vaccines. The good news is that we did not see any significant relationship between COVID-19 vaccine hesitancy and the hesitant to other routine immunization. That's what we're seeing as far as the survey. The finding from the survey is pointing out. People continue to have very strong belief in those routine childhood immunizations as against the COVID-19 vaccine. And of course, when you look at the COVID-19 vaccine as well, people have reasons why they are a bit hesitant. And those that also accept have their reason. So what we are seeing on our continent is that people are not necessarily anti-vaxxers. Rather, people want more information. And Stephen, you will agree with me that in the field of public health, the message or the messenger is as important as the message. You have the message there, very good message, but the messengers are not carefully chosen. So at the end of the day, that message does not do what it's supposed to do. So what I'm trying to say here is that possibly we need more behavioral scientists, on the continent to really engage people, engage our community on this COVID-19 vaccine. Number two, we need to empower our community health workers who actually serve as interface between the community and the global health players. We need to empower them with adequate information. We need to empower those local journalists that have the trust of the community. Because don't forget again, Stephen, one thing that is coming out of this COVID-19 pandemic is that erosion of trust capital. People have lost trust completely. So, and the only way we can bridge that gap or to bring back that trust is to work with those key players who are in the community, like the community health workers, those local journalists who are in the community, the traditional rulers, our clergymen, those faith-based organizations, those civil society organizations. So the onus is on us now to empower them, to empower them with the right skill, the right knowledge, the right tool for them to be able to engage the community. Because we have seen in Africa that when you do appropriate community engagement, the uptake of COVID-19 vaccine is surprisingly very high. We have seen it in Uganda. We've seen it in Kenya. So we need to do more, rather than saying people are not taking this vaccine, people are hesitant. I think we need to do more to find out why and address some of these issues. Africa CDC is playing a lot of role, but we cannot do it alone, including even tracking rumors on social media and addressing those rumors, working with our youth, because we know that they are the drivers of some of this misinformation and disinformation. Working with them, engaging them strategically, but as I mentioned, we cannot do it alone. We need the support of everybody, to do this and address some of those barriers to COVID-19 vaccination. Before now, it was issue of availability, which you agree with me also play a role, and some of the narrative that's also coming out from the West also play some role. Today, we said Johnson & Johnson is not safe for this, it's not safe for that. You get it? So, and tomorrow again, we say it's fine, we can use it. When you begin to have some of this conflict information, it brings about lack of trust. You get it? People begin to have second, opinion on some of these issues. So I think we need to do a lot as far as management of our information is concerned. You need to do a lot by engaging the right set of people, and we need to play a lot of role in carrying our community along. Over.
Thank you. So we have another question on this balance between the catch-up campaigns and the routine vaccination campaigns. Do you have any idea how the stakeholders are balancing the investments in these two approaches?
Well, because as far as the COVID-19 pandemic is concerned, we are not yet out of the woods yet. We know that, we are still seeing cases, people are still dying. And we know that for now, quite a lot of our partners are still fixed on strengthening the routine immunization rather than embarking on catch-up campaign. But I think whether we like it or not, the strengthening of routine immunization is as important as the catch-up campaign. Catch-up campaign for measles, for polio, for diphtheria, for pertussis, all these are very, very important. I think it's something that we need to prioritize. Currently, what we are seeing is that a lot of emphasis is still going into those routine immunization, but we need those catch-up campaigns. Over.
Thank you. And
sorry, Stephen, I think that was my question. Just to add on a little bit more, I think what I also want to ask is, because each government obviously only have their own public health expenditure budget. So I'm just kind of wondering, because COVID has emerged, it's a brand new source of burden of disease. So in terms of investment, how are stakeholders balancing the investment in COVID vaccine campaigns versus catching up? Because obviously there's no infinite amount of resources. I'm just kind of curious about how are these decisions made?
No. Thank you for that question. So let me tell you what I mean, because we work with a lot of partners as a regional or as a health agency that sits within a political organization. Most partners now are more preoccupied with getting to the 70% COVID-19 vaccination rate. They are more preoccupied with making sure that every COVID-19 vaccine is turned into vaccination. And I'm sure you are aware that on the continent of Africa, shortage of vaccine supply is no longer a problem. We have a lot of vaccines. What is a problem is getting those vaccines into people's arms, So there has been a lot of emphasis on that. Now, what our other member states have tried to do, so that we do not have a situation whereby we prioritize the COVID-19 vaccination over our routine immunization, is to begin to look at integrated approach. And some few member states have tried to do that. using the routine immunization platform to drive the COVID-19 vaccination. Because you know that in most of our member states, we have been able to use the routine immunization platform to drive our maternal and child health programs. So what member states are trying to do now is using that routine immunization platform to drive the COVID-19 vaccination. So by so doing, the resources that is coming into the COVID-19 vaccination is also by extension going into the routine immunization. So this is what we have seen playing out. But as I mentioned, there are a lot of resources that is going into COVID-19 vaccination in terms of program delivery. I hope that answers your question.
Yeah, thank you very much. Thank you.
Good.
And thank you for speaking up. I didn't, I'm sorry, I missed the point of your question.
Sorry for interrupting, sorry.
No problem. So maybe I should ask Melody to ask her question now. It'll take her a second to get off mute, I suppose.
Yes, sir. I wanted to know how the CDC is bridging the gap in the vaccine when it comes to vaccine-preventable diseases, especially with hepatitis B and the others. Thank you.
All right. No, thank you for your question. So before the COVID-19, the COVID-19 pandemic started, we do have our program towards hepatitis B elimination on the continent of Africa. With the COVID-19 pandemic, we continue to drive that agenda. We're working with partners and the government of Egypt because of their enormous experience in the eradication of hepatitis. So we continue to pay the same attention we were paying to this, our hepatitis eradication program, just like we were doing before the COVID-19 pandemic. And we continue to emphasize to our partners, who we are driving that agenda together on the importance of the need for continuity of some of these other vaccination program on the continent. And of course, through our primary healthcare system, we also continue to emphasize on the importance of all these routine childhood immunization. And as I mentioned, we did actually provided a guideline document that will allow member states to continue to run their routine immunization in parallel to responding to the COVID-19 pandemic. And we've tried as much as possible to socialize that document with our decision makers across all the member states. Over.
Thank you. So I want to ask a question about monkeypox, but I'm not exactly sure how to put this so that it doesn't sound bad. But I'm curious if there's some way you think that the continent can take advantage of these outbreaks of what has been an endemic disease that causes, has a significant burden of disease. When it gets into the West, suddenly there's renewed attention on it. Do you think there's a way that Africa CDC can somehow get that attention moved into Africa, where it maybe belongs?
No, thank you, I'm Stephen, and thank you for raising the fact that monkeypox is something that has been endemic in Central and West Africa for years now. This is the first time it's getting this sort of attention, because suddenly it finds itself in where it's not supposed to be, or where it's not known to be before now. So I think, as you mentioned, this is a perfect opportunity to get it right in terms of control and the prevention of monkeypox. First is the aspect of surveillance. I think with the renewed or with the resources that has been allocated or that will be allocated to control of monkeypox from the global north. So we believe that surely we will have what it takes to put in place a very strong surveillance system, for monkeypox on the continent of Africa, including molecular surveillance. Because we need to ask ourselves that what has changed, as far as the genome of this monkeypox is concerned. Why are we seeing it now in certain group of people in certain part of the world? Is it that we are seeing some mutations, or what? Are we dealing with another variant? Again, so we need a very strong genomic, pattern genomic sequencing capacity in that regard. And I want to believe that a lot of resources we coming through that, and we'll use this to consolidate on the African Pathogen Genomic Institute, the Africa CDC has put in place before the COVID-19 pandemic, which has enjoyed a lot of support from the due to the COVID-19 pandemic. So possibly with this monkeypox, we'll be able to consolidate on that. Number two is our diagnostic capacity. Today, Kenya has a suspected case. They have to send the sample to Senegal, Dakar. Should it be that way? No. Kenya should be able to diagnose it itself. So with this renewed interest in monkeypox, so we believe more resources will come so that we build the diagnostic capacity of most of our member states, to be able to pick monkeypox and other emerging or re-emerging infectious diseases. We believe that will also come true. I think this has also provided further opportunity in the area of clinical trials for vaccines and for therapeutics. Before now, we just believe that the monkeypox vaccine works. The smallpox vaccines work for monkeypox, at least around 85% effective, but it also has its own, some of its own side effects. You get it? So possibly this is now an opportunity to begin to look at a specific vaccine for monkeypox, a specific therapeutic agent for monkeypox. Today, we know that for the West Africa strain, it's just about 1% or so in terms of fatality, as against the Central African strain that is 10%. But now that we are seeing it in a vulnerable population, is the fatality rate still going to be the same, or is going to change? Now that we are seeing it finding itself in a vulnerable population, are we going to start talking of a new variant that is more lethal than what we have before, or is going to be going to remain at this? So these are the research questions, which resources, that might come in now should be able to allow us to begin to unpack and address. So that's the way I see it. It's a perfect opportunity to bring resources, to strengthen what we are doing as far as monkeypox is concerned, in terms of diagnostics, in terms of surveillance, in terms of therapeutics, and in terms of research to answer certain unanswered questions. Over.
Thank you. I think that unless others have questions that they will put in the chat, I'll bring this session to a close and thank the speaker once again. I wish there were a better way to show appreciation over these video calls. We'll be taking a break now. And we've got another panel coming up. Data and modeling challenges and opportunities is our next topic on the same Zoom link at 1:30 p.m. Eastern Time, which is 50 minutes from now. Thanks again, Taj, and I hope we'll see you soon. And we'll
thank you,
Stephen. All the great progress you're making.
Thank you so much. Bye.
Bye.